Hi, everyone. I'm so excited to be here with you all discussing intra-abdominal infections. So we're going to go ahead and get started. So first and foremost, complicated intra-abdominal infections is a common problem with appendicitis alone affecting 300,000 patients per year and consuming greater than 1 million hospital days. So IAI is very serious, and it's the second most common cause of infection mortality in the intensive care unit. This infection can affect many organs, and thus times can be antibiotic coverage will need to be broad in spectrum. Understanding the appropriate management, especially the duration of therapy and what broad agents will be required for specific agents will be very, very important for you all as you are navigating this. So just our checklist, you're going to read the why I cover the topic, read the learning objectives, you're going to navigate through the intra-abdominal infections handout, and then you are going to submit your muddiest points, should you have them, onto that discussion board. So by the end of this activity, you all should be able to, given a patient case, determine if the intra-abdominal infection is primary, secondary, tertiary, or complicated. You should be able to classify the type of IAI. You should be able to identify high-risk patients, recommend adjunctive therapy. So what do we do in lieu or as well as using antibiotic therapy? You want to determine if additional coverage is needed for different problematic organisms. We want to then recommend appropriate empiric and then definitive treatment. So our typical things when we're navigating through, we have these abbreviations here, just as you all see them. I want you all to be able to reference them here, should you need to. And those are our resources. So we're going to get started. So when we talk about intra-abdominal infections, we will talk a lot about peritonitis. So the cavity in which our small bowel and our large bowel and all of the important things of our abdominal section are stored are called the peritoneum. So when bacteria enters that peritoneum, it can cause peritonitis or just inflammation of that peritoneal lining there. So peritonitis can be broken into three different classifications. You can have primary peritonitis or cause spontaneous bacterial peritonitis. You can have secondary peritonitis, and then you can have tertiary peritonitis. So primary peritonitis typically occurs in those patients that are cirrhotic, so alcoholic cirrhosis. And then in those patients that have peritoneal catheters. So with cirrhosis, we know that means the patient has a lot of fluid. If they have a lot of fluid, it's easy for bacteria to be in that fluid, which can go ahead and cause infection or have or wreak havoc in that peritoneal cavity. And then also when you have peritoneal catheter use in dialysis, remember in renal, when we talked about the dialysis with the peritoneal catheter, so then you can easily inject skin pathogens into that normally sterile peritoneum space. And then if you do that, then your body wreaks havoc because it wants to get the bacteria out of that normally sterile space. You can have a propagation of infection there. So for secondary peritonitis, this typically occurs after some type of trauma or post-operative, meaning that there is an introduction of bacteria into the peritoneum. So with appendicitis or cholangitis, a lot of times in the event that like the small bowel is perforated and it leaks into the peritoneum, that's what we think of when we think about secondary peritonitis. So not like a direct introduction of bacteria into that space. So when we think about primary, that is in patients that have cirrhosis or some type of already present disease state, or we think about the catheter, we think about spontaneous or primary peritonitis because of that indwelling catheter that can go ahead and cause infection. Secondary, we think more of some type of perforation of the GI tract, and then that going ahead and causing the peritonitis. Tertiary is very similar to secondary. However, it's at that point where you've tried to get the source control and the infection persists. So it's like our scaled up secondary type of infection. That's tertiary peritonitis. And then an abscess is once again just that purulent collection of fluid. So it's when you think of just when you see photographs of just an abscess or a lot of fluid and pus separated from that tissue, but in that peritoneal cavity, that's what we think of when we think of an abscess, and that can also be present as an intra-abdominal infection. So a stepwise approach, when we think about an IAI, you want to first identify the source of the infection. So you want to think about what is it that can be causing it. You want to think about the patient presenting factors. Is this a patient that has peritoneal that receives peritoneal dialysis? Is this a patient that's cirrhotic? Is this a patient that has appendicitis? Is this a patient that has cholangitis? You want to think about those factors. What can be causing this? And then you want to determine, is it a primary infection? Meaning, if the patient is cirrhotic, if the patient has peritoneal dialysis, then you think, okay, this is a primary infection. If the patient has appendicitis, if this patient has acute cholangitis, then you say, okay, this is secondary. If that patient has appendicitis or cholangitis and you try to get source control, meaning you try to fix whatever it is that's going on there, or an abscess, and you try to drain it, and that infection continues to persist, then you say, okay, this is a tertiary infection. So once you've done this, you then want to decide, is this a community acquired infection or is this healthcare associated? So intra-abdominal infections can be two types. They can be community acquired, meaning the patient comes in from the community with the infection, or they can be healthcare associated, meaning the patient has some type of healthcare factors, meaning they're in a nursing home, or they're previously hospitalized. They're in a long-term treatment center. Then you can say, okay, this may be a healthcare associated infection. It's important that we separate what type of presentation this is, because you want to know what antibiotics should I be using. If this is community acquired, then you may not necessarily use the type of antibiotics that you would be using should it be a healthcare associated infection in a patient, right? So we want to think about that. So we know that the infections can be either community acquired or healthcare associated. And then if it is community acquired, then you have two different rankings there. It can be mild or moderate, or it can be high severity, or high risk. So you want to be able to, if you have a patient with a community acquired infection, figure out, should I be treating for mild to moderate or high risk or high severity? That high risk or high severity patient, you'll treat like a healthcare associated. What that means is you're worried about survival, you're worried about resistance, so you want to go hard, you want to scale up with the antibiotics. So that's what that means, but it'll make more sense as we move through the handout. You want to establish whether that source control was obtained. At the end of the day, the best way to overcome these intra-abdominal infections, the best way to overcome a lot of infections is, if you can, to get source control, to take that bacteria away so that the antibiotics you can get your bang for your buck. Then you want to choose your empiric antimicrobial agents after you have gotten that source control. And then you want to, when cultures return, you want to tailor your antibiotics to the more definitive treatment. And then further on, as we all know what we want to do with an infection. So when we talk about the pathophys or etiology, primary peritonitis is often monomicrobial. That means that it is often just one microbe that is causing that infection. Secondary peritonitis is often polymicrobial, and that's because you can have a leakage of you can have a leakage of different bowels. So the small bowel or the large bowel, which can be polymicrobial in nature. So below, we'll talk about just the different pathogens that can be included in these infections and where exactly we'll think about this. So when we think about the nosocomial infections or a hospital or healthcare acquired infections, that's why I told you all, that's when we will want to scale up with our antibiotics, because we know that Pseudomonas can be associated with our healthcare associated Acinetobacter. We know that multi-drug resistant organisms, so like Klebsiella or E. coli, that may not be responsive to typical treatments. Those can be what we see in the healthcare associated infections or hospital acquired ones. So that's when we think about using our bigger ticket antibiotics. So the further that we move down into our bile ducts and into our, when we think about our secondary bacterial peritonitis, the more that we begin to grab different types of organisms, so gram-negative and gram-positive. I want you guys to keep that in mind. The further you move down, the more organisms present. So first and foremost, when we think about the likely organisms in peritonitis, when we think about primary peritonitis, we oftentimes think about E. coli, we think about Klebsiella, Streptococcus. When we think about cirrhosis, so what is typically in that abdomen or in that abdominal space? We think about gram positives. We think about, so ultimately in intra-abdominal infections, we think about gram positives, as we talked about with cirrhosis. We think about gram negatives, which you can see in cirrhosis. And then we also think about anaerobes. We think about those bugs that would typically be below. So in our below area, we see a lot of gram negatives there, a lot of anaerobes there, in our below our abdomen. So we want to keep that in mind. So yeah, with cirrhosis, we think about just what can typically be in the abdominal space: gram negative with E. coli and Klebsiella, gram positive with Streptococcus. Peritoneal dialysis, we see a lot of the skin pathogens there. So we see staphylococci, we see streptococci. We think about that because we know that you need to go ahead and poke through that person's skin. It's easy for those skin pathogens to then go ahead and mobilize and cause infection in that peritoneal space. We can also see E. coli, Klebsiella, Pseudomonas. Once again, things that we would think about in our abdomen. So then when we think about secondary peritonitis in our gastroduodenal area, we see Streptococcus and E. coli. And the further that we move down, heading into our biliary tract, our small and large bowel, we start to pick up more in terms of gram negatives, more in terms of anaerobes. So you want to think about that when you're thinking about the type of infection that a patient may have. You want to think about, okay, where in the peritoneum or where in the abdominal space is this infection? And are we thinking about more gram negatives at this point, more anaerobes and all that? So at the end of the day, what you all need to know is that you would typically use broad spectrum therapy here. So if you had a patient that came in and they presented with an intra-abdominal infection and you wanted to treat them empirically, you would use something that could cover for gram positives, that could cover for gram negatives, and that could also cover for anaerobes. You want to keep that in mind because at the end of the day, you do not know the specific organism, but what you do know is that these organisms can be present should there be an intra-abdominal infection. So you want to have drugs that can cover for those organisms, gram positive, gram negative, and then anaerobes. Then you'll send those cultures off once you try to get that source control or to work on that area that's obstructed, causing that leakage of bacterial contents into that peritoneum space. And then once you did that source control, you'll make sure to get a culture right. And then once that culture comes back, you can scale down on your therapy. But at the end of the day, you want to start big. You want to be able to cover, or not even big, you want to be able to cover for the organisms that could potentially be present, depending on if it's community acquired or healthcare acquired, or if it's community acquired, mild, moderate, it'll look different than if it were community acquired and high risk in terms of how you would approach this empirically. But we will once again talk about that into more detail. So this is just a bit about the pathophysiology, which we've talked about, but this will give you guys just more context in terms of how it is that you need to go about thinking about peritonitis and what that looks like. So in terms of the pathophysiology based on the classification, so primary, that means that bacteria can maybe transported from the bloodstream to the peritoneal cavity, that being through the bowel wall, or that can be through peritoneal dialysis, that catheter. Secondary can involve the perforation of the gastrointestinal tract. So that can be through ulceration, ischemia, obstruction. And because of that perforation or that opening of that gastrointestinal tract, then you then have the leakage of contents into that peritoneal space. And that can occur from blunt or penetrating traumas, such as appendicitis or surgical procedures that could cause that leakage into that space. Appendicitis itself is not an intra-abdominal infection. Appendicitis is something that, or when you need to have your appendix removed, that's something that is not that something that would fall underneath the intra-abdominal infection arena. For some people, it's a routine, or it can be a routine type of removal of the appendix. Nevertheless, in the event that surgery goes wrong, and then you have the leakage of the contents from the appendix into that peritoneum space, then that becomes a secondary infection, meaning that intra-abdominal infection or that peritonitis is secondary to that appendicitis. So the appendicitis is the inflammation of the appendix, which made it so that the appendix had to be removed. The intra-abdominal infection, or the peritonitis, is when leakage of whatever that removal procedure was is in that peritoneal space, wreaks havoc, and then causes infection there. So it would be so when you see appendicitis there, know that we're saying it's a secondary infection caused by appendicitis, which was that primary infection. So make sure you keep that in mind. Tertiary infections occur in critically ill patients, and this can, typically is in critically ill patients, meaning that they had a secondary infection that was left untreated or that continues to persist after receiving that management of their peritonitis. So in the event that this is the case, then we call it tertiary, meaning that you tried to manage it and the management has failed. We've tried to manage it for greater or equal to 48 hours. And in this case, we may, if you were using, maybe if you were using a piperacillin tazobactam or Zosyn initially, then you'll scale up and you'll say, okay, let me use a carbapenem. And if you were using a carbapenem, then you'll consider using a beta-lactamase inhibitor, because now you're trying to throw everything that you can at the patient, and you're thinking maybe it's a matter of resistance that we haven't been able to find yet. Maybe that's why they're not responding to treatment for that secondary infection, irrespective of their source control. And then you can also have an abscess. And the abscess is just formation of the chronic inflammation that can develop from peritonitis or independently, and that can be right there in that peritoneal space. And that development can be over time. But the abscess will typically require drainage, and then after that drainage, you'll give the patient antibiotics. So a clinical presentation of the peritonitis will be generalized abdominal pain. You can see tachypnea, you can see tachycardia, nausea, vomiting. Of course, we would think about a fever, which we can see. So typical presentations of infection, hypotension, hyperperfusion, shock. If in the event, shock can be if the patient is not fluid resuscitated, and also a decrease in the urine output. And this can be in the event that you see a more septic type of presentation. So for laboratory testing, gram stains, cultures, and susceptibility of drainage of the affected region. So the gram stain is typically not helpful in community acquired, but it may be helpful in healthcare associated. So in those infections that may have come from the healthcare setting, because then you can determine whether yeast is present. That you can sometimes have fungal infections that occur in that abdominal space. So a gram stain may be helpful there, but in community acquired, we are not typically worried about those pathogens. So it may not necessarily be very much helpful there. And in the presence of community acquired infections. Cultures are useful in determining epidemiological changes and resistance patterns. So we will get those cultures because intra-abdominal infections occur in that peritoneal space, right? We said in that peritoneal space, you can have a lot of gram-negative bugs that reside there that can cause infection there. That means that resistance is can readily occur and in these types of infections, or can be seen in these types of infections, because oftentimes you can see gram-negative pathogens there. And we know gram-negative pathogens can very easily acquire resistance through those enzymes. So we will get cultures and intra-abdominal infections to guide us in accordance to how it is that we should treat these potentially resistant infections and to identify them. So culture and susceptibility results to determine antimicrobial therapy and high severity or high healthcare associated infections should be based on pathogenic potential and the density of identified organisms. So what this means is that we want to make sure that when we are treating the patients, that we treat whichever pathogen we feel is most virulent. So you may get, and we talked about the fact that these infections can be polymicrobial. So in the event that they are polymicrobial, you want to make sure that you are focusing on that organism that is indeedly the one that's wreaking havoc there or causing infection in that particular presentation of the intra-abdominal infection. So the way that you can figure that out is a lot of times we will just have to continue with broad therapy in this instance. But nevertheless, we want to make sure that we are being pathogenic specific. So for blood culture, microbes recovered from blood culture should be assessed to be significant if they have established potential. So that means that we are typically going to say that pathogens are definitively causing this infection or are virulent if they are present in greater than or equal to 2 blood cultures. So we want to make, if we see E. coli grown in both bottles or both blood cultures, then we'll say, okay, this E. coli is definitely what's causing this infection here, this intra-abdominal infection. So for the CBCs, we will likely see elevated white blood cell counts. And so we will see elevated bands, elevated neutrophils, and we know that will be indicative of infection. So as I told you all, these intra-abdominal infections can be one of two. So they can be community acquired or they can be healthcare associated. So for community acquired infections, that means that these are not related to surgical or medical interventions, and they usually are the result of an underlying disease state or condition. So when we think about cirrhosis, when we think about the fact that the patient has peritoneal dialysis, why we don't really think about secondary infections being community acquired or healthcare associated. If you had to put primary peritonitis in one of these, it would typically lean into more of the underlying disease state. But also for community acquired, if you notice someone has, diverticulitis, which is just inflammation of the diverticulum, in the event that they have some type of condition that would cause for them to have any type of odd GI abnormalities. However, they have resided in the community and they haven't had any major healthcare exposures, then you will typically treat them as though it's a community acquired infection. In the event that it is healthcare associated, meaning that the patient had a surgery and then they had a GI perforation, meaning that, like I explained with the appendicitis example, say they had appendicitis when they had that surgery, there was an accident and maybe some of that bacteria or the contents of the surgery leaked into that normally sterile peritoneum space and then caused infection, then you would say, okay, this is a healthcare associated infection. So community acquired infections are stratified based on severity. They can be broken into two main distinctions. So they can be mild to moderate, and then they can be high severity. So that means you want to first say, okay, is this patient coming in with a community acquired infection or is it healthcare associated? So say now we've said, okay, they're coming from a community. This is a community acquired infection. Then you want to say, is this mild to moderate or high severity? That's how you'll navigate treatment. So for high severity, those will be those patients with Apache 2 score greater than 15, meaning that they are at more risk of having a bad outcome or dying from this infection. We know the higher the score is, the worse off you are. Extremes of age, so if the patient is greater than 65, we know that they don't have that typical normal response to therapy. If they have immunosuppression, so if they've received a transplant, if they have any type of malignancy or cancer, if they have inflammatory bowel disease, or if they have rheumatoid arthritis, any type of inflammatory disease, then we want to put them there for high risk. If they are immunocompromised, this meaning that they have low albumin levels, we know that means they have low protein or they're not able to fight off normal infection. If they have poor nutritional status, if they have organ dysfunction, inability to achieve source control, then in that case, we want to put them at high risk. So you can have a community acquired infection and still be high risk. That's okay. But that'll just, so you will treat these infections that are high risk a little more aggressively than you would treat those that are not high risk or mild to moderate. But that doesn't mean that they can't be community acquired. So an example, let's say you have a patient, the patient comes from the community. So the patient comes from their home. They have inflammatory bowel disease. They present with intra-abdominal or peritonitis. So I say, they came in, they have IBD, inflammatory bowel disease, and they come here and they say that, hey, and we figure out that they have peritonitis. So I know that one, they didn't come from any type of healthcare setting. I know they came from the community. So I'll say, okay, it's a community acquired infection. And then when I go to think about whether they're high risk or mild to moderate, I'll say, oh, they have an inflammatory disease. So they're community acquired, and then they go underneath high risk. And that's how I'll go ahead and navigate that treatment. So treatment includes 3 main modalities. So you want to drain, you want to get that source control. You want to resuscitate in the event that the patient is showing signs of hypotension or the need for hemodynamic resuscitation. And then you want to do an early administration of antimicrobial therapy. You want to do source control first, honestly. In the event that the patient can't undergo such source control, meaning that maybe that source control will cause more harm than good, then you'll start antibiotics. But it's very important that you get that source control. That's how you're going to see your biggest bang for your buck in terms of antibiotic treatment. And moreover, you want to make sure that the antibiotics are not halted by just a continued propagation or a continued increase in bacteria at that site if you haven't done anything to go ahead and drain it or eliminate the bacteria there, or at least decrease the amount of bacteria there. So for non-pharmacological options, you want to do secondary peritonitis requires surgical correction of the underlying pathology. So drainage of that purulent material is critical for the management of the abscess. So if they have an abscess, you want to make sure you drain the abscess. If they have secondary peritonitis, or say they have appendicitis, you want to make sure that you go ahead and remove that appendix if it hasn't been removed, or if the appendix has been removed, then you want to go in and fix whatever it is that caused those contents to leak into that space. So for secondary infections, you want to make sure that you go back to whatever that primary site is and you fix that issue. For abscesses, you want to make sure you drain. So fluid resuscitation is something that's done in the event that the patient appears to be or appears to have a lack of perfusion. So that can be shown by hypovolemia, hypoperfusion, shock. So you can see that with hypotension. You may have a decline in your blood pressure if you have a MAP less than 60. If you see a patient has a decrease in their output of fluid, then you say, okay, this patient is clearly having a problem with perfusion, or this patient is not perfused well, meaning that we want to resuscitate them. So we will go through this in more detail in the class, but this is very much what we would do in terms, it looks a lot like what you would do in the event that a patient is septic. And we want to make sure that we stay away from colloids. So when you are resuscitating patients in the event that this is necessary, then you want to make sure that you use crystalloids, so normal saline. You can use D5.5 normal saline. We can use lactated ringer. But we want to make sure that we stay away from these colloids. It's because these colloids are very big. And if you refill this space too quickly, then you may end up seeing more harm than good. You want to be very careful. We want to remember that fluids are also drugs, right? So we want to be careful in how we go ahead and administer them. But colloids you want to stay away from because they are big, they are packed, and they can cause dysfunction, organ dysfunction, if we do give them in a patient that is suffering from or requiring aggressive fluid management. So when we think about the treatment of secondary, so we are focusing with treatment regimens with this class, we are focusing on secondary peritonitis, secondary and tertiary. We are not focusing on secondary, tertiary in the event the patient has an abscess. We are not focusing very much on primary peritonitis. Primary peritonitis, you will go ahead and you will likely treat the patient with ceftriaxone, which covers for all those bacteria that we went ahead and we talked about. So we will not spend time on primary peritonitis as it occurs in very select populations. We will focus on treatment regimens. They will be mostly catered to those patients that have secondary peritonitis. Tertiary is when they have secondary and they don't respond to therapy. And then with abscesses, we'll go ahead and we'll treat them in accordance to this protocol. So please keep that in mind. So when we have a patient, and let's say that they have a community-acquired infection, if they present and the patient has a mild to moderate infection, then we can use monotherapy. So we'll say that they present and you have a patient that comes in, they have diverticulitis, you want to treat them with something, you can give them a mild to moderate, you can give, and they have mild to moderate infection, meaning they have none of those indicators that we went over for high risk, high severity. You say, okay, we can do cefoxitin, we can do ertapenem, we can do moxifloxacin, and we know that cefoxitin covers for gram-positive, the gram-positives we need to cover for, the gram-negatives we need to cover for, anaerobes, right? Down below, you want to get back to those anaerobes that are down below. You can use ertapenem. We know that's our low-scale carbapenem therapy, right? You can use moxifloxacin. We know that's our fluoroquinolone that has anaerobic coverage. If you want to use combination therapy, we know that for our cephalosporins, we do not get anaerobic coverage. So we want to tack on metronidazole there, right? But you will use our lower scale kind of cephalosporins. You can also use your fluoroquinolones. I tend to stay away from those when we have other agents we can use here. For our high risk or high severity. So remember when I told you all, this is when you will kind of scale up with your antibiotics. So here we see our Zosyn, we see our imipenem, we see our carbapenem therapies here, doripenem, meropenem. So we can treat with monotherapies in high risk. And then we can also treat with our combination therapies in the event that the patient has a high risk infection. But we would then, we see cephalosporins here, but we see our cephalosporins that have our carbapenem, we see our cephalosporins that have our pseudomonal coverage rate. So we see our ceftazidime, we see our cefepime, but we also know that no matter what, our cephalosporins do not cover for anaerobes. So we need to put on our metronidazole. The cephalosporins that do cover for anaerobes are cefoxitin, cefotetan, and we see that our cefoxitin is here, but only for our mild to moderate. And yeah. So we will only look at that for mild to moderate, community acquired. That's the only time we'll look at cefoxitin. So our intra-abdominal infection included in community acquired infections can be appendicitis, cholecystitis, cholangitis. So those can be there in our community acquired infections. So for our healthcare associated infections, so what we use here to guide us is just Pseudomonas resistance to ceftazidime. So in the event that we have less than 20% resistance to ceftazidime, then we can use our Zosyn, we can use our carbapenem, we can do that as monotherapy. For combination therapy, we can use cefepime or ceftazidime plus metronidazole. So once again, we're jumping straight into using our agents that provide that larger spectrum of coverage. So that's pseudomonal coverage in our healthcare associated, because we know Pseudomonas can be a healthcare associated drug, right? So that's when we will jump right ahead into our larger scale therapies. And then for combination therapies, once again, are using our agents that cover for Pseudomonas, our cephalosporins, but we know that the cephalosporins, with the exception of the one we talked about, do not cover for anaerobes, so we have to tack on metronidazole there. So in the event that you have greater than 20% of resistance to ceftazidime, so if we see that we have increased resistance to ceftazidime for monotherapy, we can continue to use our other agents, because who cares? Ceftazidime isn't included in our monotherapy. We can still do what it is that we need to do right there for our monotherapy. And then for our combination therapy, if it's greater than 20% resistance to ceftazidime, then you want to go ahead and you will use cefepime or ceftazidime. And then you can tack on an aminoglycoside plus the metronidazole. Or I have also seen that we will use these monotherapy options that you see listed in the greater than 20% resistance to ceftazidime for Pseudomonas. You can use the piptazole, and then you can tack on an aminoglycoside. You can use the carbapenem, tack on an aminoglycoside. And the reason that we do this is because if we see resistance to ceftazidime, then we know that, or that we can kind of say, okay, there may be some type of ESBLs present here, or extended spectrum beta lactamases. There must be some type of class C or AMP-C production here in this hospital. So we want to make sure we're throwing on another antibiotic with a different type of mode of action to go ahead and overcome that Pseudomonas there. So it's different ways that we can go about treating these patients. But a lot of times we can go ahead and use these monotherapy options, or you can use that combination therapy option that we see right up top with the less than 20% of resistance to ceftazidime. So just special populations and things for you all to think about as you're navigating through therapy. So for antifungal therapy, as I previously stated, you can sometimes find Candida or different fungal species that grow right there in those type of intra-abdominal infections. So you are going to tackle antifungal therapy if both criteria here are met, meaning that you see Candida growing in the cultures and it's a high severity infection. So if it's a high severity community acquired infection, or if it's healthcare associated, then you will tack Candida on. You will not see, if you see Candida in community acquired and it's not a high severity infection, then you won't really need to go ahead and tack on coverage there. If you do see the Candida, if you do have fungal cultures that come back and they're positive, you see Candida growing in both of those cultures, and the patient also presents with high severity factors, meaning maybe the Apache 2 score is high, different factors like that, then you'll say, okay, let me go ahead and treat them with antifungal therapy. If it's healthcare associated, once again, you get those 2 cultures back with the fungal growth. You see that they are already in a healthcare setting and they're coming for treatment for that infection, then you say, okay, let me tack on treatment here. So for empiric therapy, you will typically use fluconazole. It is reasonable if a patient is critically ill to tack on or to, instead of fluconazole, use another antifungal agent. And we really want to avoid amphotericin B, as it is a very harmful, strong, and a very powerful agent to use in these infections, especially when fluconazole typically gets the job done. But we will follow up and talk more about invasive fungal infections towards the end of the course. So don't stress yourselves out trying to make sure that you understand this information to the highest degree as of yet. It's just important that you know that if you do get fungal organisms that grow in 2 cultures and the patient presents with a high severity infection or a healthcare associated infection, then you can go ahead and tack on antifungal empiric therapy, and that empiric therapy is typically fluconazole. So also we know that enterococcus is in that GI area. So in the event that the patient has received a cephalosporin as prophylaxis before they've gone into surgery or after they've come out of surgery, in the event that you have a patient that is immunocompromised, in the event that a patient presents with valvular disease or so valve replacement, a lot of time enterococcus can be found there in those types of infections. Then you can go ahead and you can put vancomycin on as enterococcal coverage if you have a patient that's not performing well. So say you treat a patient for greater than 48 hours and you say, oh, this patient isn't performing well, they're still not doing very well. Oh, I remember that after this patient got out of their surgery for their appendicitis, we treated them with, we gave them cefepime following that surgery. Oh, let's tack on vancomycin because we know that cephalosporins do not have activity against enterococcus. And then you can get that increased growth in enterococcus, which can then cause some type of, which can then present an enterococcal type of infection. So we want to make sure that we tack something that will provide coverage against enterococcus in the event that these factors are met in a patient. So you will put on vancomycin for that. And then you will tack on vancomycin once again if a patient presents, and if you're worried about MRSA, and you're worried about MRSA, if once again you have a patient that's not getting better, they have some type of documented colonization of MRSA, meaning that when you see the patient and you get their colonization information back, it says MRSA colonized, then you say, okay, we'll go ahead and we'll tack the vancomycin on here just in case. And then if they have, if they received any other treatment, so say that they came in for, they had a healthcare associated intra-abdominal infection, you treated them with the monotherapy meropenem, they did not get any better, then you can then tack on vancomycin because it didn't have any type of MRSA coverage, and that may potentially be a cause. So clinical pearls, these empiric antimicrobial therapy recommendations are not applicable to primary peritonitis, or with primary peritonitis, you will typically lean more into using ceftriaxone. With upper GI bleeds, you will manage more with some type of PPI or something of that sort to stop the bleed, not really antibiotics. So antimicrobial regimens used in secondary infections should be broad in spectrum, as we discussed. And single agent regimens are effective, but have the benefit of being less nephrotoxic when compared to the aminoglycosides. So as I talked about with using the monotherapies, you would typically want to use like meropenem or piperacillin-tazobactam, these agents that do cover for the gram-negative, the gram-positive, and are anaerobe, versus having to go and use that cefepime plus the metronidazole plus the aminoglycoside. And the reason that, I say this to you is because the aminoglycosides have a lot of associated toxicities, one being that they are very nephrotoxic, they could be ototoxic. Both of these may in turn be irreversible. So you really want to be careful when using these agents. So increasing resistance is a concern with bacteroides, which is something that you're worried about, excuse me. So we want to make sure that we're careful with treating with clindamycin, cephalosporin, which is why we saw cefoxitin there. And then for Enterobacteriaceae, we want to be careful with using ampicillin, so Bactam, and then fluoroquinolones. So once again, I told you all, I kind of stay away from using the fluoroquinolones. And ampicillin, so Bactam is not even listed on what I gave you all in terms of your go-ahead treatments. The tigecycline is also mentioned in the guidelines for therapy. However, tigecycline has been shown to have increased or to present with increased mortality in those patients that do present with just bloodstream infections, or in some instances that can be caused by intra-abdominal infections. So we want to be kind of conservative with how we use tigecycline, and maybe reserve this when we have multi-drug resistant organisms, so documentation of that. But or kind of if you don't have anywhere else to go, if the patient is on their last treatment option, then we'll lean more into that tigecycline. So for follow-up on definitive therapy, so we want to narrow in the event that we can do that. And in the event that we are able to go ahead and get source control, we can treat for a shorter duration, so maybe like 4 to 7 days. And it is okay to keep anaerobic coverage on board, which will ultimately be the case when you are using these monotherapies for about 4 to 7 days, especially if when you find out that an anaerobe is what's causative of the infection. I typically lean more into that longer duration of treatment. So maybe instead of the 4, I'll lean more into that 7. Just personal pearls for you all. So for targeted therapy, we have for ESBL, dependent on susceptibilities. So when we say ESBLs, or extended spectrum beta lactamases, I actually have changed this, and that will be reflected. But as we talked about with the Marino trial, we really want to lean more into using our carbapenems, our beta-lactam, beta-lactamase inhibitors, or also we have the new therapy, ribociclib, which can potentially be utilized. It has the typical tetracycline pharmacophore, but it has some slight modifications. The ribociclib does, but it also provides coverage against those organisms that we see in intra-abdominal infections, and can overcome different modes of resistance. So based upon that Marino trial, we know that if extended spectrum beta lactamases are present, then we want to go ahead and use the carbapenems versus using the piperacillin-tazobactam in many cases. So that will be fixed on you guys' handout sheet. For in the event that Candida is there, we can use, in the event that Candida species is resistant to fluconazole. Fluconazole is our first line. So if you see growth in 2 cultures, you can use the fluconazole. If the patient continues not to respond, then we'll follow the algorithm as such. And then we want to transition to oral therapy when the patient is clinically stabilized as following. So duration of therapy can be about 4 to 7 days. So 4 days has been shown to be sufficient in our mild to moderate or lower grade intra-abdominal infections with adequate source control. Please refer to the STOP trial, which I have posted for you all to read. And then inadequate source control, if the patient is not clinically improving, can be continued for weeks. So if the patient is not improving and things of that sort, you can continue drainage or potentially therapy will have to continue for a longer duration if we're not able to get source control there for that patient. Source control, as I previously stated, is really going to be our key to success. If you can drain out or pull out the bacteria or eliminate that source of bacteria, then you can ultimately use the antibiotics to continue to eliminate that inoculum. But whatever it is that you can do to stop that source of whatever it is that's causing that infection will be optimal to what it is that we see in terms of therapy. All righty, let me know if you guys have any questions.